what about combination therapies? So the second option I mentioned was osimertinib combined with platinum doublet chemotherapy. It's 2 chemotherapy drugs together. It's our standard chemo regimen we tend to use for this type of lung cancer. So the FLAURA2 trial was the big randomized trial that now compared this big combination to osimertinib alone as the comparison arm and looked for outcomes, how people did. And again, that primary endpoint, the key thing they were looking at was progression-free survival. And here again, you can see here's the progression-free survival curve on the left, again, showing that now osimertinib, there's the blue line, the chemotherapy combination is the yellow line. And you can see again, improvement in progression-free survival from about 16 to 25 months if you add chemotherapy up front. So we're shifting that curve up a little flatter again. A lot of times we think of actual sort of long-term overall survival as our gold standard for these sorts of upfront combinations where you're taking on more toxicity. Right now, we haven't seen a significant difference in that yet, but the data is immature. So we're waiting to see long-term how people do if they get this sort of combination up front. Side effects are, as an oncologist, what we expect, where we see the side effects of osimertinib, so the EGFR side effects, and we see the side effects of chemotherapy. And chemotherapy side effects are most commonly things like tiredness, low blood counts, nausea are kind of the big ones we're thinking about. And again, this regimen's a little more intensive where there's an extra chemo drug in the first 4 rounds of treatment. That's those blue bars. You can see all those side effects are higher than later on once you're no longer getting the extra kind of stronger drug and just in maintenance. And that I think matches our clinical experience as well. The first 3 months are a little harder. And as you go forward, people are feeling a little better on therapy. Now, I think the big question is who really needs combination therapy and who could start with EGFR inhibitor alone. We think, it's not all one diagnosis. People are being diagnosed with very many different stages of disease and different sort of aggressiveness of disease. And these are called subgroup analysis. They looked at a couple different features of the tumor and said, how do people do with and without these features? So with or without brain metastasis, with and without detectable EGFR mutation in the blood, with different types of subgroups of EGFR mutations. And I highlighted in green the 2 that kind of weigh on me the most. And you can see that in the top left, if you have a brain metastasis, your benefit to adding combination therapy is higher. It's almost more than a year benefit. And that probably speaks to more aggressive disease, harder to treat disease. The combination might be more important. And then in the middle bottom, I highlighted if your EGFR mutation is not detectable in a blood test, it probably means you have slightly less aggressive disease or less extensive disease at diagnosis. And then people did really well with the pill alone, only a 3-month degree of benefit. You can see not a big difference in those curves. And people really had a very good progression-free survival with just monotherapy with osimertinib alone, so option 1. But you can see each subgroup is different. That's something we think about with any individual when we're talking through what makes sense for one person versus another.